Hey, good morning, everyone, and welcome to UroNurse. I'm your host, Vic Sidis. Welcome to the show. Yeah, you probably can tell from my backdrop, I'm not at my regular studio. I am on the road here. This is where I'm at. I'm in the Shenandoah Mountains in Virginia. So we're staying. That's the view out of my window. I wish I could show you that side, but it doesn't work too well for the camera. But it's a beautiful place to be, but we're take UroNurse wherever we want on the road. Hey, if this is you're following us live, you can follow us on YouTube, LinkedIn, Facebook, and X. We're always there every Saturday at 9 a.m. Central Time. First time checking us out at UroNurse, be sure to check out our website at uronurse.com. Best place to go and learn more about the show, visit some of our other great podcasts, and also check out our great gold sponsors that bring us the show every week. Also, the best place to go to find all of our past episodes, 142 past episodes. So there's plenty to watch. I heard a lot of you like to listen to us in the car. No problemo. Just go ahead and check us out on any of your favorite podcasting apps like Apple Podcasts, Spotify, iHeart, Amazon, and YouTube Music. About a half hour after the show, I move it over to an audio version so that you can also get it on the audio version. This week, I've got a great subject. We're going to be talking about those purple bags. A lot of you have seen them before, and we're going to talk to you about it. And I've got the experts on this to join us today. Hey, folks, welcome to the show. How's everybody doing today? Lori and Todd. Todd is the expert. Welcome to the show. So I'm going to have Lori swing in here. Why don't you give your introduction?
Good morning. My name is Lori Atkinson. I have not been here in a while, so I'm glad to be back. I am a certified urology registered nurse. I have been a urology nurse for 26 years now, and I currently work at a large urology practice in Geneva and Winfield, Illinois.
All right. Welcome to the show. And the real guru, as he even put on his name badge here, chronic urinary cath guru, is Todd Thompson. Todd, welcome to the show.
Good morning, Vic. So I'm Todd. I'm a master's prepared nurse. I work for the VA in Tucson, Arizona, and I specialize in chronic urinary catheterization, home visits, and dealing with patients that have long-term urinary catheters.
Great to have you on the show. Todd really is the inspiration for this purple catheter. Although I think a lot of us have seen it and dealt with it. Recently, Todd gave a presentation for our Chicago Metro chapter, and I was looking at his slides, and in the back, he had this slide of a purple bag, and I'm like, that's the one I've got to talk to about. So we're going to bring up our show right now, if I can remember where I'm at. There we go. Let's get up our slides. Todd and I are going to both present on this. And hang on one second. I'm working remotely, so I don't have my big, gigantic screen, so I got to move a few things around. But so purple urine bag syndrome, or PUBS, is what we're going to be talking about. And that was that slide that Todd had sent. And that was a reminder for me. And so one of the things I decided to do, and I've done this in the past, is send out a survey to all of you to kind of get an idea where everybody's at on this subject. And so I asked, what's your role in urology? And not to any big surprise, mostly RNs and advanced practice nurses. And then how much experience do you have? And most of our audience is pretty experienced. 64% of them been in this field for over 10 years. Think about urology. We all love it when we get into it. What type of practice setting? Again, not surprising. Most of us are in outpatient clinics. And then I said, have you ever had a purple urinary bag syndrome in your practice? And 96% have seen it. So even though it's rare, a lot of people have seen it. If you encountered it, how often do you see it? And I was kind of surprised on this one. So sometimes I thought some maybe just once or twice, but this was actually over 2 times a year. Most people have seen this. Then I asked, in which patient population do you normally see this, just to kind of get an idea? Most are long-term catheters, but elderly, bedbound, patients with chronic constipation was kind of low, chronic renal disease pretty low. Just some of the things I thought, let's get some thinking out there of what can cause this. And then I asked, how familiar are you with the causes of PUBS? And somewhat familiar is the bulk. So I think that's really where most people stand in urology. You've heard of it, you've seen it, but you're not really experts in it. What do you believe contributes most to it? And so I asked a few things I threw out there. Bacterial infections was the number one answer, but alkaline urine, constipation, diet, and I'm some honest folks out there, I'm not sure. And I think that really covers most of the causes. We're going to discuss those in this talk. And how do you manage it? That's another big question. How do you actually take care of this? And the majority of people are just catheter, bag, and replace the whole system. Some urine culture, antibiotic treatment, bowel regimens, observation only if asymptomatic, no specific protocol. That was pretty big, and I don't know. And I think that, probably the way our practice manages it and the way Todd maybe manages it could be different. So we're going to talk a little bit about how we're both managing this. And do you think pubs is a sign of infection requiring treatment? And I like that most people said no, not necessarily. So that's good. I think sometimes you do want to treat, not always. Has your facility provided education or training on pubs? And Todd and I were talking about this before the show started. But really no formal training out there for this particular problem, or in a lot of urology, we said, right, Todd?
That's correct. Yes.
So, and then I asked if you'd be interested in more education, and of course, you folks are. So, what is it? It's a rare condition. It's usually found in long-term catheterized patients, and it's that purple discoloration to the urine collection bag and tubing, often benign, but signals underlying issues. And this is kind of a breakdown of what we're going to talk about, but what causes the bag to turn purple? And it's just a conversion from bacterial metabolism in the gut to pigments that come out into the urine that react through the liver and produce these two dyes called indigo and indirubin.
I can't pronounce that very well either.
But that's where the purple comes from. And
Right.
Interestingly, some people have the misconception that it's the urine that's turning purple, and it's not. You need the bag. So it takes all of these combinations to cause this problem.
Right. It's actually pretty surprising that the first time you see it, you go over and examine the catheter bag, and when you turn it, you can see that there's very clear urine in the bag. It's just along the edges. So it's the bacteria really interacting with the indigo and attaching to it. So it really is only the bag, not the urine at all.
Yeah. All right. Now, so one of the things I mentioned there was tryptophan, and I mean the real thing, tryptophan, that great stuff in turkey that makes you feel so sleepy after you have a nice turkey dinner. But there's a lot of things that are high in tryptophan. So dietary requirements require that to cause this to happen. But it's in almost everything: turkey, chicken, eggs, cheese, milk, yogurt, beef, lamb, fish, especially salmon, tuna, and cod, which is probably the most consumed fish, and pork. Also, it's high in a lot of plant-based sources. So if you're one of those that are just having a plant-based diet, tofu and soy products, pumpkin seeds, sesame seeds, sunflower seeds, nuts, all sorts of them, legumes, quinoa, oats, and dark leafy greens, the stuff you're supposed to eat, right? This one would really drive my wife nuts. She'd always have a purple bag if she had a permanent catheter, because dark chocolate, she would never give that up. But dark chocolate, bananas, and whole grains. Did I miss anything, Todd?
No, I mean, that's really what is causing the high protein, high tryptophan amount. But it's important to say that high protein on its own will not cause purple bag syndrome.
Yeah.
It's really three factors, and we didn't go over the deck, so I'm not sure if you're getting into that, but the diet is the first thing.
Yep. Yeah, we're going to probably catch that. I'm going to talk a little bit about that biochemical pathway, just so that our audience, who's pretty smart here, can see what we're talking about. So tryptophan, we talked about just now what those things are. Is the amino acid found in dietary proteins, as Todd had said. Gut bacteria, especially in patients with constipation. And that's one of the things I wasn't aware of. Break down tryptophan into indole. And then it requires the liver to convert indole, which is absorbed in the bloodstream. It converts it to the indoxyl sulfate, which is then excreted in the urine. Urinary bacteria then come in. That's where they fall in. They convert indoxyl sulfate. So in the urinary tract, certain bacteria, we'll talk about which ones those are, produce an enzyme, and it takes indoxyl sulfate and indoxyl phosphatase. And these enzymes break into indigo, the blue pigment, and indirubin, the red pigment. And we know if we mix blue and red, we get purple.
That's right. And, it's important, and I'm sure we'll get more into it, but it's not a particular bacteria
Yeah.
that will cause the problem. Many different bacteria can do this enzyme breakdown and create the indigo and the indirubin, which can be confusing because if you do like a culture and sensitivity, you may not get a particular bacteria that is the causative factor.
Yeah, I was always misled that it was the Proteus. That was the big one. That it was if they had a Proteus infection, you're going to get that purple bag. And as you said, in research, it shows it's not just Proteus. It's although I know it's one of the big culprits.
Well, Proteus is a big culprit for just about all the chronic urinary problems.
Yeah, it causes a whole heap of problems. Yeah. So anyway, the pigment, but now here's the other thing is just those pigments alone would not turn the urine purple. So the pigment has to react with the plastic. So indigo and indirubin mix on the catheter tubing and the urinary bag surface, especially where urine stagnates. And the plastic of the urine bag absorbs those pigments and produces that vivid purple color.
Right. Especially vinyl.
Yeah. So, I mean, it's a combination, and that's what's really kind of, I think, misleading. You think there's something going on, that the urine is turning purple and dyeing everything, and it's not. It has to have that plastic, like you said, vinyl especially. And there we go. That's what we see. So I think we all have recognized it. And I tell you, the first time I ever saw it, I thought, what the heck's going on with this patient? There's got to be something wrong with them. I've never seen purple, and I thought purple urine at that time, but as you study it, you learn.
And it's also very upsetting to the patient themselves. Whenever the patient gets a purple urine bag, they freak out, and you get a call, you'll get anxious family, and it can take a little bit of work to kind of calm them down the first time it happens.
Absolutely. And the other thing I always associate with it is that smell. It's probably you can tell that patient out in the waiting room when you call them in, because that odor is really penetrating.
I mean, maybe you got a better nose than I have.
I do. Unfortunately, I have too good of a sense. I always say you can always tell somebody who has that kind of bag because they're wearing a lot of Old Spice.
Yeah. But I do think of like Klebsiella having a particular smell. So
yeah.
It makes me wonder if it's the bag, the indole itself, or maybe the bacteria that has the smell.
I'm not sure what releases it, but I do know it has a more, like a typical E. coli infection. You really don't smell that, but these always, to me, have a lot of odor. So we did say we were going to talk about the bacteria. Now, I was always early on, and I thought it was strictly Proteus, and I got that mostly because when I saw these purple bags early on in our practice, and even our physicians weren't all that aware of what was going on. Just get a culture, see what it is. And that's what we did. And it was always coming back Proteus for us. So that's why we kind of honed in on that. But as you said, you've seen some of these other ones also, right?
Yeah. And it's important to remember that patients with long-term urinary catheters often have multiple bacteria. Yeah. And so it's not uncommon to have 2 or 3 different bacteria come back in your culture and sensitivity. And, my frustration had always been that I would send out a culture and sensitivity and it would come back as contaminated sample, because the lab, if they have like 3 or 4 different bacteria in it, they don't think it's treatable. And that would always really frustrate me because, I was always very diligent about drawing the urine sample and the culture and sensitivity. And then when I sent it to the lab and they said contaminated sample, I got pretty pissed off, thinking that, I'd go to war with them. I did this right. And once you realize
it was a clean catch, it was not a contaminated sample.
Right. I changed the catheter. I had done all the things perfect. And then they say contaminated sample, and I took it pretty personally. But, that contaminated sample just means it has multiple bacteria in it.
Yep. Yeah. And I think if you work with your labs, a lot of times you can get them they know if it's coming from our office and we write down that it's a catheterized sample, they'll run it.
Yes.
They'll give us a breakdown, but it's like you said, their go-to is 3 or more species. It must be contamination, and then they don't do that sensitivities or anything. They don't even identify. So.
But they will do it if you ask them.
Yep. The other thing is urine pH is a big part of this too. It's more common in alkaline urine. As we know, normal pH or neutral pH is 7. So as you go low numbers, you're acidic, and as you go higher numbers, you're alkaline. And all of these are alkaline urines. If you check the pH, they seem to all have high alkalines.
Yeah, but is that a part of the purple urinary bag syndrome, or is that a part of like the protease, which breaks down? The alkaline urine is part of the process of the protease converting urine into food, essentially.
Right.
So I honestly don't know if the alkaline urine is a byproduct and has nothing to do with the purple urinary bag syndrome or not.
Kind of that chicken and egg thing, which is really is it a byproduct, like you said, byproduct, or is it a cause of?
Right.
So, but we do know that the alkalinity does help promote bacterial enzyme activity, but we know bacteria produce this urease producing bacteria raise the urine pH. So
Correct.
We've got that, the both things working. So which means one of the treatments might be just trying to get patients to acidify their urine.
I honestly haven't found that to be true. First off,
No.
Acidifying urine is a really tough thing, because if you have like protease that's converting acid, I'm sorry, it's early here, so I'm having kind of a breakdown, but the urease producing bacteria is breaking down urine to produce food, right? And it creates an alkaline situation. So the more acid you add to the system, the more food you're giving to the bacteria. So adding vitamin C or trying to acidify the urine is not generally effective. So if you put
lemon juice isn't going to fix your problem.
The lemon juice deals with the citrate, not the acid. And if you're going to try to acidify urine, it's real easy to do a pH before and after, and chances are you're not going to see a difference.
Good point. All right. So who's at risk? Elderly, makes sense. Female, bedridden or institutionalized, long-term Foley catheter. We said alkaline urine and constipation. The one thing I did question is, out of that group, why females? Why are they at higher risk? And so I did a little research, and we know shorter urinary urethra causes higher risk for infections, so that made sense. But they said that statistically, there's more long-term catheter use in elderly women because of incontinence issues, immobility, and dementia. Also,
yeah, I would add to that inappropriate long-term catheter use.
Absolutely,
women have less need for a long-term catheter,
right?
Than men
especially do. That's why kind of the bells were going off, because I'm thinking, us guys, we get big prostates, you're obstructed, or maybe from long-term obstruction, you burned out your bladder, you're going to need a long-term catheterization. Women don't have that issue usually.
Right. And the advancement with incontinence supplies for women has been dramatic in the last 5 years. There's a lot of, suction style systems that are very effective. And so this is a good opportunity to say, why do they need that chronic urinary catheter?
Absolutely. This is really, as you say, this is what we need to stress in our education. You really want to prevent this problem, get rid of the catheter. That's going to be the ultimate goal for all these issues. But statistically, that's what they're doing. We know that it's just easier to manage somebody in a nursing home with a catheter than it is to treat the incontinence with these other issues. And females have a higher rate of chronic constipation due to pelvic floor issues and medications that they take. I wasn't aware until I did this talk, was the amount that constipation can lead to the increased indole production in the gut.
Right. So and, honestly, that's the biggest problem. And whenever I see purple urinary bag syndrome, I really start thinking constipation as a major rule out, because the more a patient is constipated, the more bacteria they have in their gut.
Yeah.
Simple as that. Okay.
Yeah.
If you're not moving that bacteria out, okay. And women, I think, have a tendency to be more constipated because they're like afraid of having to use the bathroom in public, and it's more of a work because of social issues and fears. So I generally will see women, bedbound women with chronic urinary catheters, as having more constipation than men.
Yeah. Yeah. I was really surprised because, like I said, this was one thing that, in my career, I never even thought of, is constipation being part of this purple bag syndrome.
Well,
It's good to learn stuff, right?
Yeah. and constipation, when you're dealing with a chronic urinary catheter, is a major problem for a lot of things, because you can actually clog a urinary catheter by the pressure of the rectum pushing on the urethra, and that can actually cause a clogging. So anytime you're dealing with complications due to a chronic urinary catheter, you need to make sure that they're coming out the other end properly.
Yeah.
Don't just think urine.
We concentrate so much on urine, we sometimes forget about the bowel in urology, but it's just as important. So signs and symptoms, we talked about that purple discoloration of the bag and tubing. Most of the time, these patients aren't complaining of other symptoms, but they can get typical UTI symptoms like fever, dysuria. And as I mentioned, to me, I think it has a really bad smell.
Like I said, I think you're just better at smelling than I am, but it really is very asymptomatic, and I don't think of purple urinary bag as any sign and symptom of a UTI whatsoever, because it's something that's happening in the tubing and in the bag. And when we start thinking about COTI, we need to think about systemic type of things like fever.
Right.
And so I don't put it on your COTI list at all.
Yeah, good point. Good point. Is it dangerous? We just said usually benign. If there's an underlying UTI, constipation, things that you can treat, poor catheter hygiene, and there's some concern about if there's a risk of an ascending, as you say, something that could turn into a sepsis. But we know normally this is not going to be something you see. I've never seen sepsis with a purple bag.
No. And really, what it really indicates to me is the big person that you need to yell at for purple urinary bag syndrome can be the cook. That if they're having a high protein diet, I remember
the tryptophans, the proteins,
the tryptophan, going out to a patient's home to change a suprapubic catheter, and he's eating a Whataburger while I'm trying to change the catheter, and he's got purple urinary bag syndrome, and every time his son came to visit and brought him hamburgers and beef jerky and things like that, he would get more purple. So I always kind of have that vision of this guy sitting there eating a Whataburger while I'm trying to deal with his catheter.
Yeah, it's always been one of the parts of, with having you as a guest on the show that's been so great, is that, all these problems that we just kind of encounter, most of us don't really, I think, spend the time to break down what could be causing this outside of just treating it. Everybody wants to just treat things, throw some antibiotics at it, it'll be better. That's not the way to do it. Think through what are these causes that we can treat? Simple things, changing diet, getting rid of constipation, much healthier for the patient overall.
Oh, yes. And constipation is really one of the major symptoms or causes, in my opinion, because you're dealing with all that excess bacteria in the gut. Yeah.
And research is supporting that too. We diagnose it simple. You can't miss it. It's that purple color. Urinalysis and culture if symptomatic. So somebody with a fever, obviously. But checking for the constipation, hydration status, a lot of elderly don't drink enough. Now, let's talk about management. So I think most of us replace the catheter bag and catheter when we see it, but it'll just come back purple the next time they come in, right?
Oh, yeah. Yeah. 99 to 100% of people with a chronic urinary catheter are colonized with bacteria. and the bacteria is in their bladder. It's on the external portions of the urinary catheter. So changing the bag is not going to decrease their bacterial load for more than a very short amount of time.
Yeah.
So, one of the things that I've often done with these patients is that we had volunteers that were making little colorful bags that fabric bags that they could stick their urinary catheter bag in when they were in bed or in the wheelchair. And, it took away some of the questions and, you do the education, but hiding the bag, I guess, would be part of the replacement.
Yeah.
So you're not really changing anything by replacing the catheter bag. You're just making it look better for a day or two.
Yeah. Now, one of the things that we did early on, between myself and the physician that I was working with, is we would just treat them with the antibiotic. We'd hit them with Cipro because we're seeing Proteus, which is best treated with Cipro, and a lot of times they come back, bag would be clear the next time you change it, and it may go away for good.
But now, are you treating the UTI or are you treating the bacteria in the gut?
No, we were treating the UTI.
Okay.
It was based on what we got from the culture. Yeah.
Maybe the bacteria in the gut was being affected by the Cipro, which was breaking down the system of high bacteria in the gut going to the liver and then going to the bag. So, people who get on an antibiotic can get diarrhea caused by the bacteria. I mean, by the antibiotic.
Treats their constipation.
And you're decreasing the bacterial load in the gut with an antibiotic. So, I would argue that you may have been treating the purple urinary bag syndrome, but not necessarily by destroying the bacteria in the bag.
Yeah.
Okay. Because as we know that when you have biofilm formation, it's really hard to get rid of that bacteria with a antibiotic in the long term.
Right. For those that haven't seen your lecture, the biofilm is that covering that goes and protects the bacteria from the antibiotic.
Right. And it's smarter than we are most of the time.
Absolutely. And that's what causes all of those blocked Foleys that we deal with all the time.
Correct.
But no, that's a good point. I think, certainly my management is different now than it was back then when I first saw it and didn't have any really good ideas what was going on. There wasn't even a lot of literature published, for those of us that have been in this field for 40 years. It's, some of this stuff was not out and published, but I think now it's going to a multi-focus approach would be most sensible, right?
No, I totally agree. But
diet,
it's interesting. What is the antibiotic doing? Is it really working in the urinary system, or maybe it's working in the gut?
Yeah. And I think at this point we don't treat with antibiotics unless there's symptoms.
Right. It's completely
fever, right. Exactly. And I think the big thing is educating your staff so that they're aware of what they need to look for. So let's see here. So address the alkalines. Now we kind of talk a little bit about it. Fluid intake is good no matter what. That will help dilute urine. Should help maybe normalize pH, but maybe not.
Right. And, when we talk about the system of the tryptophan in the gastrointestinal tract being converted in the liver and then going into the urine, none of that system has to do with urine pH. So I think, increasing fluids is always good unless we're dealing with someone with congestive heart failure, blah, 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 hypernatremia. And we're definitely, when people are constipated, they're usually dehydrated, right?
Yep.
Okay. And, getting rid of electrolytes in the urine with calcium, magnesium is also good to help prevent clogging. But again, this is one of those things that I don't think definitely helps a patient, but I don't know if it's targeted directly at the system of purple urinary bag.
Yeah, so it's what we're doing to try to address the alkaline urine is probably helping, but not helping the pH.
Right.
So again, consider dietary changes, encourage foods that acidify the urine. Well, these would be the ones that I was talking about: cranberries, meat, high protein, vitamin C, those things. But you said it's probably not going to alkalinize or acidify the urine very well.
Right. Well, definitely getting rid of the proteins and high protein foods
Mhm.
will help. You know, cranberries, you're going to get me trying to remember all these big words. The protective layer of the bladder, the glyco.
Right.
Cranberries help build that up, which helps decrease bacterial load.
Keeps
Okay.
bacteria from sticking.
Right. Thank you. And so, you know, I can see some advantage in the cranberries and the meats, and, you know, you and I can have a fist fight about the vitamin C and citrus foods.
Yep.
So,
All right, good. So again, these are just kind of review prevention strategies. Good catheter hygiene always makes sense. Regular catheter changes, and managing constipation. That's the biggie that I don't think I was thinking of. Fluids and educating caregivers. So we'll kind of go to a case study here and just throw
wait,
it to you.
you
Oh,
mind if you go back to the other slide real quick?
Yeah.
So does regular changing bags decrease the rate of UTIs?
I would say no.
Yeah, I would say no too. So,
Yeah.
you know, regular catheter changes are good. Okay. Changing the bags doesn't really make a difference. And, you know, one of my issues about regular catheter changes is that the more often we change a catheter, the more likely we are to cause trauma to the urinary tract.
Mhm.
And a catheter is actually good for up to 12 weeks, according to manufacturer's instructions. So,
Yeah.
you're not necessarily getting rid of bacteria by changing the catheter. So changing the catheter more frequency may not make a difference. But, you know, I really believe that we should be changing catheters less frequently than every 4 weeks
Oh,
based
I
on,
agree with you there. That's just been, people's habits. They just
right,
were taught that in school, every 4 to 6 weeks, change the catheter. I
right.
early on just started saying, this is crazy. These catheters don't look that bad when I see them, and started pushing. My routine was always about 10 to 12 weeks.
Exactly. And that's what is on the manufacturer's instruction. You know, read what the 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 lubricacious catheter by
Mhm.
Bard. If you look at the thing, it says it's good for up to 12 weeks. Now, there
Yeah.
are some catheters that are out there that are only good for 4 weeks, but they're usually only used in surgery. They're a straight latex or catheter. But we
And
should,
and patients seem to appreciate not coming in so often either.
oh yeah, definitely. But
Because
you know,
the
the regular catheter changes is not going to solve the problem. It's just going to make them feel
yeah.
better. And we should really be basing our catheter changes on the clinical presentation of the patient and the manufacturer's guidance when it comes to
Yeah,
how long that catheter will last.
absolutely. All right, so here's our case study. A 78-year-old woman comes in with long-term Foley catheter, develops purple urine bag discoloration, has no fever, mild constipation. What would you do? It's all on you, Todd.
Okay. Well, you know,
Hey,
the
I
main
didn't
thing
put
I would,
chronic urinary catheter guru on my name.
the main thing I think I would do is reassure the patient.
Yeah,
Okay, that, you know, this is a benign situation. It's just caused by a multitude of factors. It matches her outfit. I wouldn't get too worried about it. Um, and, you know, kind of explain that this is something that just happens, that it's okay.
yeah,
I certainly wouldn't want to treat her with antibiotics. She has no symptom of a UTI, and purple urinary bag syndrome is completely separate from a UTI symptom, a CODI symptom. I would obviously want to treat the mild constipation,
hmm,
maybe talk to her about dietary changes, go to my volunteers and get one of those cute little bags that she can put her Foley in,
yep,
so that it's not as obvious. I also don't like how high that bag is. It
yeah,
probably needs to be a little lower
yep,
for good urinary drainage, but that has nothing to do with what we're talking about.
yeah.
So reassurance, treat the constipation, and talk a little bit about diet.
Yeah. No, I agree. I agree. That's 100%. One of the big drawbacks of that is people like to kind of work fast, get the patient in and out,
Hmm.
and they come in complaining. Handing them a pill is a lot faster than sitting down and talk to them about their dietary needs and hydration and all the other stuff. But if you really want to treat the problem, that's what you need to do. Take the time.
That actually brings up a good question. I've never seen any literature patient handouts on purple urinary bag syndrome. I mean, I really prefer one-on-one patient teaching, but you're right, it does take longer.
Yep.
But, maybe we should have some resources when it comes to uh, giving information to the patients on this
Yep.
thing. I have absolutely no handouts, no little information. I really don't even know of a website to send them to or something.
Well, now I'm got a website to send them to,
Right.
europatient.com. If you go to
Oh, there you
UroNurse, you
go.
can find Europatient. Europatient.com is also got a collection of handouts. And
Oh, okay.
I promise you there will be a handout on purple bag syndrome and
Okay,
what to
well, we
do,
really need it because
because
the
we
the
do.
ed the patient education is just not out there.
That's one of the reasons I started the Europatient podcast, because patients didn't have a resource. So I, along with the videos explaining what it is, I always create a handout, and I'm going to be presenting this, I think next week, to the Europatient group. And I'll have a handout every time I put a handout in at that same time so they can download something. But you're right. There's not a lot of information out there. So myth busting, not a sign of sepsis. Urine isn't truly purple, and we don't need to treat with antibiotics. I'm just going to skip through here. This was the last slide I wanted to go over. So I did ask a question, any comments or experiences that our audience wanted to add, and there was some responses. It usually disturbs patients due to the color and odor. We teach them that the color, clarity, and odor do not indicate infection. We discuss chronic colonization and only send culture and antibiotic if symptomatic, fever, nausea, chills, and pain. They're right on the mark there. We re-educate about cleaning the drainage bag and with distilled vinegar between uses, and encourage PO fluids, keeping bowels regular, add fresh lemonade to the diet if sediment is present. We also have taught cath irrigation and renocidin installations if no bladder stones are present. We don't do renocidin for purple bag syndrome, though.
God, no.
That's
And
just
and
for,
honestly, flushing can make clogging worse.
yeah.
And that is one of my other little pet peeves about flushing. It is not solving the problem. It can actually irritate the lining of the bladder. It can actually cause bigger problems. But you and I can talk about that subject on another thing.
Yep.
Cleaning drainage bags, you know, is probably going to help them feel a little bit better. But, for a long time, I had a lot of questions about cleaning drainage bags because, in a acute hospital situation, it's closed bag, you want to keep an enclosed system.
Mm-hmm.
At home, people are breaking it open. And so I felt like trying to clean drainage bags could actually increase the risk of infection. But my studies have actually shown, and my research have shown, that cleaning drainage bags doesn't increase or decrease the risk of infection. It has no bearing on that.
Good point. Years back, somebody wrote a paper on it. That's interesting. I think they did send me that paper too. Patients are usually very curious when this happens to them. Absolutely. Great initiative. Thank you. This has always baffled me. Yeah, so I'm not the only one out there with that question mark. Tough problem to deal with. Absolutely. And we see it on our long-term catheter patients. We don't consider this a UTI in the absence of other symptoms and don't do anything about it. Perfect. Right on.
Right.
So we're going to open it up to our audience for questions and comments. And let's bring Lori in on the screen here. Hey, Lori, did you learn something?
I absolutely did. I wasn't sure. I didn't know about the constipation or the tryptophan. So I have nope. In the beginning, the beginning of my career, the first time I saw it, because nobody tells you about that. It shocked the crap out of me. I was like, what is that? And of course, way back in the day, it was like antibiotic, antibiotic, antibiotic. And now I see that and I'm like, it's fine. It looks pretty, right? It's totally fine. It doesn't matter. You're special. You got purple, purple bag. We don't change it if it's a purple bag. Of course, usually they're there for the catheter change anyway, but we just tell them to, just continue fluid. So now I know about the constipation in the diet, which, yeah, I did not realize that. It was great.
I was kind of surprised about the two chemicals that caused it. And the only reason I knew the colors red and blue made purple was I watched during COVID, I started watching this Bob Ross painting because it's just entertaining. And he's always mixing the paints and he'd mix them together and get the purple. I'm like, there's where that purple comes from.
Pretty
but
little
it's really about the liver breaking down tryptophan by deaminization. So it's creating waste products of the breakdown of the tryptophan, the protein that then travels through the bloodstream into the kidneys and then out to the bag.
Definitely.
So, it's
think about that diet and constipation, those two factors. So we did get a couple comments. A lot of folks here watching. Fran said, nice. Nisha said, hi from California. Good morning from Plainfield. See, somebody else got up early, Todd. Plainfield, good morning. Good morning from Seattle. Another person got up early. Todd feels better because he's coming from Arizona. And Fran Foley said her bag matches her outfit. Think that's a coincidence, Fran? Me and Mid-Journey, I can make anything happen. Anybody else has questions or comments, feel free to put those into the comments zone and we'll bring those up today. But otherwise, we'll just keep chatting about catheters and what we should do. I don't see any other questions. So, I think that, this has been fascinating. And Todd, you also sent me a slide. I didn't put it into my deck, but there's more than just the purple color urine you were showing me. There's all sorts of different things.
Yes. I actually think it's kind of fascinating when you start looking at the different colors of urine and what can cause it. You can have milky urine. You can have many different colors that can indicate changes in a patient's condition. Now, most of them are somewhat benign. And so when I got into purple urinary bag syndrome research, I was actually like, let's look at other types of urine. And if you go back to like the Middle Ages, doctors that studied urine were actually like the top of their field. And they were they were like soothsayers. So they would actually like study urine to determine what was majorly going on with like the king or queen or princes. And that was like the number one highest paying medical job in the Middle Ages was urine taster.
I was just say, diabetes was diagnosed from tasting the urine.
Exactly. So, this was top of the field back several hundred years ago. One of the things that I've noticed in an acute hospital situation or even in clinic settings is that doctors don't really look at urine anymore. And so if you're seeing a change in the patient's urine, if you're seeing something unusual, you should bring it up as a possible symptom. Not necessarily of infection, but hey, what, is there something going on in the kidneys? Is there something going on in the liver or an endocrine system that maybe this is going on? So don't assume that a doctor is paying attention to that. They really very rarely look down at what's going on in the urinary system.
That's one of the old time urologists that always checked urines. I mean, our routine was to do the UA dipstick. In fact, before the machine brought it, we just did it, visual. And then we spun it down and looked under the scope. Every patient that came in. And we did actually 2 urines on male patients. We did urethral urine, the first part, and then the second part was the bladder urine. And we look at both of those separately. So
That's
I mean,
pretty fascinating, actually.
yeah. I mean, that was any male patient that came in, we did that automatically. So we gave them 2 sample cups. And I'll tell you a quick story. So I always give them a cup labeled 1 and labeled 2. And I'd say, so I want a little bit in 1 and the rest in number 2. And somebody came back with a urine sample and a stool sample. So always got to be careful how you explain that.
Well, let's hope they weren't following the instructions and that was just the result, because that would have been pretty scary. We had a couple questions in there.
Yeah, we do have a couple here that came in here. Charlene said appreciated, and Amy said how to prevent infection with chronic Foley catheter. And I'll let Todd just address that one.
Well, let's have another subject. First off, what is considered an infection with a chronic urinary catheter? Okay, you're going to have bacteria in the urine. 100% of the patients will be colonized with bacteria. So you can't use a bacterial count. You can't use the culture and sensitivity when it comes to bacteria in the bladder. Okay, you just need to educate patients that they're going to have bacteria in their bladder. You can't use color, you can't use smell, any of those things. You just got to completely rule out. So it's really about systemic symptoms, the fever, the flank pain, those type of things that you need to focus on. I kind of think about chronic urinary catheters and bacteria as what you want to do is keep the hedges trimmed. You know, you're not going to get rid of you're just trying to keep the garden under control, you know, and it's a completely different philosophy from getting rid of the bacteria. You know, we need to get rid of that philosophy of bacteria is the enemy and we have to completely eliminate it from the urologic system. It's a natural part of the urologic system. We now know that, you know, bacteria is all over our body, everywhere, right? And
yeah, the human biome
the human biome, exactly. And having a chronic urinary catheter disrupts that system and can cause an overgrowth in bacteria in certain areas, but it's still part of the human biome. And what we need to do is keep it under control and not think that we got to get rid of it. And so we're really talking about bacterial infection into the bloodstream, not into the bladder.
So Amy did add some of the symptoms that she was talking about. So fever, chills, confusion.
Right.
I think
So
that's a good point, as confusion in the elderly is sometimes a sign of urinary tract infection that's not always recognized.
sometimes
That's a hard one, because you get the
Yes.
family members that come in and they're like, oh, I think she has or he has a UTI, because they're confused, or well, it could be just because they're older and, you know, it's not always due to UTI. It's hard to differentiate sometimes.
Yes. And this is an argument that I have, or discussion I have sometimes at the SUNA conferences. It's really great going to the conferences because you get all of these different opinions. But the number one cause of confusion in elderly is not UTI. And so we need to make sure that we rule out the other causes before we start thinking of urinary. The big thing that I see is dehydration. You know, you have an elderly person, they have a change in their urine that's dark and smelly. Well, the problem is they're dehydrated. You get some fluids into them and the confusion will resolve before. And, you know, with antibiotics, sometimes they're drinking a little bit more because they're taking the pills maybe. But definitely do not think of confusion as the number one, you know, go to UTI. Now, if you're a urology nurse and you see confusion in an elderly person, I think we have a tendency to think UTI, but that's not the number one cause.
And sometimes you'll see a patient who's normally not confused and they suddenly become confused, and that can be the cause. So it is a symptom that we don't always, we don't always see, but it can be, yeah.
Right. I'm not saying it's definitely not the cause, but definitely, you know, work down, you know, and I start with dehydration, you know, delirium assessment, and UTI is part of that, but don't jump automatically to confusion. I mean, UTI is a cause with confusion.
All right, we have a couple more questions that came in here. Raj pointed out that rhabdomyolysis can also cause brown urine. We were talking about we should have you come on as just to talk about all those different color urines. I'd like to invite you to the show for another date.
I think that it's rhabdomyolysis, because I know my daughter actually developed that. She went into renal failure, so a lot of I think it's due to the fact that their kidneys are shutting down.
Yeah, I mean, it's the breakdown of the red blood cells in the muscle causes the dark urine due to heme staining of the urine.
Mm-hmm.
Okay.
And Susie Swain sent in, what can you say to the patient with chronic catheter that always wants urine culture with every catheter change, thinking they have and it's UTI with no symptoms?
Education. Right.
And as we said, that's the hard thing to do. Patients want a pill. We grew up in this age where you take a pill for everything, and it's not the way. It's, as we talked about in Purple Bag Syndrome, look at all the simple things you can do. Change your diet, get rid of constipation, all these things that can be done that don't require any medicine.
Right. But, you're really looking at someone who's kind of got that old style approach to, culture, antibiotic. And I've dealt with a lot of family members that every time something happens to their grandmother or mother or something like that, they're like, I need an antibiotic. And it takes a lot of education to kind of break that cycle.
Yeah, I remember when patients were used to that and we did that. Now all of a sudden we're saying, nope, we're not doing that anymore. And they just freak. They just don't get it. So we had to educate them very well.
Yeah. And thankfully, I think we made a lot of those changes because, we were causing what antibiotics we had left. We're not developing a lot of new antibiotics, causing them to be resistant to everything. And it's really been, I think, the medical side that's been at fault for that, for overtreating.
Yeah. And, if I have people that want to take a pill to make it better, I have recommended a high quality cranberry concentrate pill.
Yeah.
There have been some studies to show that it may make a difference over the 12-month period to decrease the rate of UTIs. But it's still kind of in that wavy gravy type of thing where the studies haven't been high quality. But it does give them something to focus on. It gives them a pill that they can take that they think that they're going to help them. And it is having some help. And I'm looking into D-mannose as a alternative also that may help. But it does give them something to focus on.
Absolutely. Yeah. And drink plenty of water with it too.
And drink plenty of water. Yes.
And Raj pointed out Allura is one of the cranberry supplements out there that you can utilize.
I think Allura is actually, they're not, it's not going to be Allura anymore. I think they've changed as of this week, I believe, to something called something MD. So it's something, it's changed names. I just wanted to throw that out there because we got this box of this new stuff, but they're saying that Allura is not going to exist anymore. So.
And Nisha has education, and we really have to deny requests for UA based on malodorous urine and color alone. I agree, Todd. Systemic symptoms are key. Documenting vitals is key. 2G D-mannose, that's the one you were just talking about, has been helping in women. So a nice comment there, Nisha. So this has really been great. I think I love doing these types of talks where I get an expert, in to kind of discuss what they've seen in their practice and kind of tackle some of these things that are not real common, but I think we really need to be thinking, beyond the gut reaction of just do this every time, just treat it with an antibiotic, change the catheter, think about what we're doing. That's what I like to really do in my practice, is to think about what's going on and how we can make things better and not necessarily just treat with medicine. So I'm going to put a little clip in for next week's show.
This program provides healthcare professionals with the latest insights into advanced prostate cancer management to enhance patient care. It equips nurses and advanced practice providers with the tools to critically evaluate the efficacy, safety, and clinical application of new and emerging therapies. Participants will learn strategies for personalizing treatment using biomarkers and clinical factors, including intensification approaches for non-metastatic and metastatic disease. The program also explores the roles of the healthcare team in improving patient outcomes in community urology settings. This will prepare participants to integrate evidence-based therapies and strategies into practice to improve survival and quality of life for prostate cancer patients. Earn one free contact hour. Join us May 3rd at 9 a.m. Central Time to learn more.
Yeah, so get a free contact hour. I don't know about you guys, but biomarkers, I'm always struggling with trying to keep track of what biomarkers should be used, when they should be used. So I thought a good review on that would make a lot of sense. And I got a comment from Todd. Thanks. I've had fun talking about this. Absolutely. Always a pleasure to have you on the show, Todd. Your expertise, your little second line is not wrong. You are the guru of obstructed catheters.
Well, again, the only reason I got into this was that I kept asking questions and no one could give me the answers. And, you know, there aren't a lot of people that focus on chronic urinary catheters because they're kind of a forgotten population in a lot of ways that that when a patient has a chronic urinary catheter, I feel like the urologists are kind of done with them. And it's left to us to manage. But they're a very vulnerable population. There's a lot of people who have chronic urinary catheters that don't need them. And there's a lot of questions about how to manage them over time.
That's probably the thing we didn't stress enough is if you really want to get rid of purple catheter, get rid of the catheter. You know, intermittent catheterization for most patients is very well tolerated.
Yes, and I totally agree. And your conversations about management of urinary incontinence using different supplies, there's been a lot of advances into this. And, you know, anytime you're dealing with a problem with the catheter, your first question is, why do we have this catheter?
It should be your first question, definitely. And we did get a nice comment from Nisha. I agree with Vic, and Todd's points have been spot on. All right. Well, Lori, thanks for coming on the show today, too. It's always good to have another expert to kind of round everything out.
Good to see you guys.
So good seeing everybody. And next week, we won't have any experts on because of it being a contact hour. It's a definite 1 hour show, so I don't have any time for any comments, but we'll always have experts on other times. Thanks again, Todd, for all your help, and we'll see everybody next week on UroNurse.
Thanks, everyone.
Thank you.